Hello, my name is Professor Cathal Kelly, Chief Executive Registrar at RCSI, and I'm delighted to welcome you from all around the world as you join RCSI for the 43rd Millin Lecture, taking place as part of RCSI's annual Charter Week. The RCSI Millin Lecture is a prestigious award and open to all of the surgical specialties. It gives me great pleasure to invite the President of RCSI, Professor Ronan O'Connell, to introduce the 43rd Millin Lecturer.
It gives me great pleasure to introduce the Millin Lecturer, Mr Colin Peirce, Consultant Surgeon at University Hospital Limerick, the title of whose lecture is Electrodes to Robots, Evidence-Based Change in Surgical Practice. Colin exemplifies the best in Irish surgical training. Following basic surgical training, he undertook research in an animal model about which he will speak, conducted a randomized controlled trial, and was a lecturer in surgery at UCD before progressing to higher surgical training. He chose colorectal surgery as his specialty interest and completed a fellowship in colon and rectal surgery at the Cleveland Clinic before returning to his native Limerick as a consultant surgeon. There he has led the introduction of robotic techniques into colorectal surgery in a careful and methodical way. He has continued his interest in clinical trials to generate evidence to support or change clinical practice.
Mr. President, Mrs. Vice President, members of Council, distinguished guests, colleagues, trainees, friends and family. It is the greatest honour of my career to date to present the 43rd Millin Lecture, and notably this is the first to be presented to an online as opposed to an in-person audience. And as much as surgeons we like to be the first to do anything, I'm sure you will all join in me in hoping that I am both the first and last in this regard. Terence Millin is a renowned surgeon, famed for pioneering a new approach, the retropubic approach to prostatectomy. He first wrote on this in 1945 and 2 years later published this book detailing his initial experience of his first 20 cases, thus allowing urologists forevermore to read about his experience and to copy his technique. We honour him each year at the Millin Meeting and in the delivery of this lecture, of which the chosen subject is one that should be of clinical interest, embodying original research. Like all those who have stood at this lectern before me, I sought to see what, if anything, I have in common with Millin prior to delivering this lecture. And in short, not a lot. But like Millin, I qualified from medical school in Trinity College, Dublin, and the year of Millin's death was the year of my birth. Thus, having never met him, nor knowingly met anyone who did know him, I believe that the goals and aspirations of my career to date are inherent on the Millin ethos: to improve the outcomes for patients undergoing surgery through evidence-based advances in healthcare. And to that end, this journey will bring you on my surgical journey, from hypothesis to practice change, from benchtop to bedside to console. During my basic surgical training, I worked here in the Mater Hospital in North Dublin, and I worked under the leadership of our now President, Professor Ronan O'Connell, who himself is a surgical innovator and was pioneering the use of sacral nerve stimulation. As we can see depicted here, that is where a stimulator is implanted in the subcutaneous tissue of the patient's buttock with stimulation of nearby sacral nerve roots through electrodes. And this was used for those patients who had debilitating fecal incontinence, who otherwise would have been confined to suffer in silence or have a colostomy cited. And while the initial results are very encouraging with success rates of 70% or more, it became quickly apparent that the mechanism of action of this was unknown. And thus Professor O'Connell and his research team set about determining this. And it has been known as far back as the early 1980s that it is not just trauma to the sphincter muscles themselves that occurs during childbirth, leading to incontinence, but also damage to the pudendal nerve, which is vulnerable at a number of sites due to either a compression or a traction injury. And indeed, prior work from our group had demonstrated that symptomatic patients presenting to a dedicated clinic, nearly 40% have evidence on electromyographic or EMG testing of pudendal nerve neuropathy. Thus, and with the aids of grants from the above institutions, and under the daily tutelage and guidance of Dr. James Jones, I undertook my MD research in University College Dublin, where we hypothesized that pudendal nerve injury during childbirth damages the smaller sensory fibers, thus reducing the drive to the patient's cortex and making them less aware. And we see this in the clinical context, where patients will tell us, oh, I didn't know that I needed to defecate, and I was unaware of having the incontinent episode until it had happened. And we further hypothesized that by introducing SNS to these patients, we would increase the somatosensory drive, restore their cortical awareness, and reduce their symptoms. To put that in diagrammatic form, the injury to the pudendal nerve affecting preferentially the afferent or the sensory drive, leading to a reduction in cortical awareness, and that potentially the application of sacral nerve stimulation would increase that sensory drive again and increase the cortical awareness of affected patients. I was fortunate to join the laboratory shortly after my predecessor, Mr. Ciarán Healy, had developed and published on an animal model simulating the compressive effects of childbirth. In the top two photographs here, we see that model, the female virgin Worcester rat being the animal of choice, and the insertion of two pediatric Foley catheters into the retrouterine space with the inflation of the balloon for a set period of time. Alongside this model, Ciarán created a positive control model with dissection of the inferior rectal nerve, which is the equivalent to the pudendal nerve in the human, and compression of this using a cerebral aneurysm clip. And Ciarán was able to show that both of these models resulted in external anal sphincter atrophy and also initial denervation with subsequent reinnervation. And there were being other models postulated by other authors at that time, but in our letter to the editor of Obstetrics and Gynecology, we highlighted our concerns with these, and our model has subsequently stood the test of time. For my first experiments, I sought to replicate what Ciarán had shown, i.e. that the model is reproducible. And once again, we looked to determine sphincter atrophy, but specifically how much. And we saw quite a lot. Indeed, not only did we see significant atrophy of the external anal sphincter, but also of the internal anal sphincter, a finding commonly seen at endoanal ultrasound of symptomatic patients, and thus clinically relevant. And similarly, we also saw atrophy of the external urethral sphincter. Again, we commonly see patients presenting with dual incontinence. Of course, we needed to confirm that the inferior rectal nerve in the rat is directly equivalent to the pudendal nerve in the human, and it has a dual nerve supply, i.e. both motor and sensory. And to do this, we used a number of tracers: fluorogold, a neuroanatomical tracer, and activating transcription factor 3, or ATF3, which is a molecular marker of exotomy or nerve injury. And here you can see in depiction, we would dissect out the inferior rectal nerve, label it with fluorogold, and 5 days later harvest both spinal cord and dorsal root ganglia. In the upper right here, we see positively labeled fluorogold neurons at the level of Onuf's nucleus, i.e. these are the motor neurons. And in the lower photograph, we see dual labeled fluorogold and ATF3 labeled neurons, i.e. at the level of the dorsal root ganglia, i.e. the sensory neurons, thus confirming that yes, this is the perfect nerve to simulate the effects of injury as concerns the human. So now, having identified that there was a significant sensory component to this nerve, could we see what would happen at the cortical level in the animal model? And we did this through the study of somatosensory evoked cortical potentials, whereby peripheral stimulation of the nerve is recorded by placing microelectrodes on the contralateral cortex when an evoked potential is produced. And what we were able to show was that there was a significant reduction in the mean amplitude of evoked potentials in both the crush and balloon compression models versus unoperated controls. Or in other words, that these models were significantly reducing the somatosensory drive. And you might say, well, maybe you were stimulating less axons in each of these. So we harvested each stimulated nerve, resin embedded it as shown here, And across all three groups, it was not due to a difference in axon number that led to these findings. So now, knowing that there's a direct sensory effect, we wanted to see exactly which sensory neurons were most affected and to what extent. And once again, we returned to ATF3 staining. The top left, we see an unoperated control animal with minimal, if any, ATF3 staining. And on the top right, that of a balloon compression model with significant ATF3 staining. And we were able to show that both models had significantly increased sensory injury compared to unoperated controls. And more interestingly, when we looked at the specific neurons that were being most affected, they were those with the smallest diameter, i.e. the smallest ones were the most sensitive to injury, the C afferent fibers, which is what we think is happening in the human clinical context. At that time, I departed the laboratory, but Karen Griffin, in completing her PhD thesis, applied sacral nerve stimulation to these models. And in these very elegant experiments, where anal canal stimulation was performed and with microelectrode array, evoked potentials were recorded, she clearly showed that with the introduction of SNS, the evoked potentials greatly increased in amplitude. Or in other words, that our hypothesis was proven, whereby the application of SNS leads to an increased somatosensory drive, thus making this animal model perfect for studying in terms of the human context. And this is now how clinicians perceive SNS to work today. My time in the laboratory, of course, had made me well capable of proceeding to patient and clinical trials. And thus, looking at this, the pyramid of evidence, something well known to us and indeed a favoured question of our trainees in Journal Club, where systematic reviews and meta-analyses stand at the top, for many of us, the randomised control trial still remains the gold standard. And I was fortunate to have the opportunity to work with Professor Colin O'Herlihy here in the National Maternity Hospital, and courtesy of a grant from the Health Research Board, conducted my first randomised control trial, the so-called EBAPT trial. And this trial focused on ladies sustaining third-degree tears at childbirth, where the current management was immediate repair, discharge on analgesics, antibiotics, and stool softeners, with pelvic floor exercises, and then return to a dedicated perineal clinic at 3 months postpartum. If you remained symptomatic at that time, dietary measures, Imodium, Fibogel, and potentially referral for biofeedback physiotherapy, and if all of those measures didn't work, referral to a colorectal surgeon. And thus we thought maybe we can reduce the amount of women coming at 3 months postpartum who are symptomatic if we institute some therapy immediately after the third-degree tear. And we hypothesized that a group of women who applied early home biofeedback physiotherapy would have improved anal manometry scores, or in other words, that their sphincter musculature would be working better than a group of women who were managed with pelvic floor exercises alone. And for those of you unfamiliar with biofeedback physiotherapy, in this context, it was the insertion of an intraanal probe for a set period of time, a set number of times each day, and the machine feeds back to the patient to let them know that they are performing these exercises appropriately. We approached 145 women and randomized 120 in a 3-to-1 ratio, 3 pelvic floor exercises to 1 biofeedback physiotherapy, namely because the machines are expensive, we didn't have a huge amount of them, and they were being taken out by the patient for a 3-month period. There were no statistically significant differences between the patient group demographics, albeit a trend towards more instrumental delivery and higher birth weights in the biofeedback group. And I was very excited about this. I felt we were going to produce a finding that was going to completely change the way we managed these ladies. And alas, we didn't. And we produced a negative finding, with no difference in anal manometry scores between both groups at 3 months postpartum. And this was disappointing, but this is clinical research. And similarly, no difference in symptom scores, or indeed in quality of life scores. And while I was a little downbeat regarding these results, it really was hammered home per se when this commentary came from a now colorectal consultant colleague in the United Kingdom, who wrote that the authors rightly state that we do not know how best to manage women following repair. And that remains the case following this study. Hard hitting, but this had certainly taught me the difficulties in running randomized controlled trials and to spur me on to run more. And indeed, I met this commentator at the time of my FRCS clinical examination, but decided we might discuss the trial at another time. So that led us on to further work, and surgical site infection is something that really perturbs us all. And I was always concerned about it during my training in terms of the morbidity associated with it, the cost associated with it, and more so now in my consultancy, as there's nothing worse than a patient who is ready to go home, developing an SSI and having to stay in. The costs can be hard to quantify, but from this study in the Netherlands, a little over 10 years ago, where they looked at all different surgical subspecialities, ultimately, if you develop a surgical site infection, your overall healthcare cost doubles. Similarly, in Leicester, where they looked at a little over 100 patients undergoing elective colorectal surgery, 27% of whom developed a surgical site infection, and interestingly, of those, 50% had been discharged home by the time of diagnosis, i.e., the surgical site infection occurs in the community, not in front of us at the bedside on our wards, and thus we often may not really know the true incidence of SSI. And when they looked specifically at all costs associated from operation to 30 days postoperatively, each SSI led to an additional costing of 10,000 sterling. And thus, under the then guidance of my trainer, Professor Calvin Coffey, who's now a colleague and great friend, I set up the PICO trial. And I must pay special note to Peter O'Leary, who took this over following my departure from Limerick and saw it through to fruition. And in this trial, we hypothesized that the incidence of surgical site infection would be reduced with prophylactic application of a negative pressure wound therapy dressing versus a standard dressing in elective patients with closed or primarily closed laparotomy wounds. This is the PICO dressing from Smith & Nephew. Easy to apply, it alarms if the seal is lost, it applies a negative pressure really to get rid of any potential exudate or seroma formation, and it retails at €145. Everyone had their abdomens prepped with chlorhexidine. There was a standardized closing set of each wound with a change of gloves prior to closing the wound. We used skin clips and then randomized our patients, of which there were 50, and we analyzed 49, one being lost in the treatment group due to the PICO dressing being inadvertently removed on the first post-operative night and replaced with a standard dressing when it alarmed at ward level. When we look at the type of patients, well, as you would think, we don't commonly undertake laparotomies electively anymore in the minimally invasive era, but these sort of patients are the ones that we are operating on. The majority in this study being overweight or suffering with obesity, having had previous abdominal surgery, and having clean contaminated or contaminated wounds. And so to the results, where we saw a significant reduction in the surgical site infection incidence at 30 days postoperatively in those patients who had negative pressure wound therapy, of 8% at 30 days versus 32% in the control group. Now, I've presented this data nationally and internationally on a number of occasions and often get cited about that high incidence in the control group. But I would say to you that when you follow your patients strictly for 30 days, your own surgical site incidence will be higher than you might anticipate. And indeed, I will also show you that ours in our control group was not out of keeping with many other trials. We also looked at the wounds day 4 because many patients were going home on day 4, day 5, and albeit there was twice as many surgical site infections at that time in the control arm, this was not significant. What was significant was the mean length of stay, far longer in patients who developed an SSI in the control group versus those in the PICO group. Now, yes, there can be other things leading to increased lengths of stay in our current hospital system, but this result is certainly noteworthy. And we do know that an SSI will increase your hospital length of stay when diagnosed in hospital. And there was no difference in patient satisfaction scores between the groups. And when we looked at all the potential predictors of a 30-day surgical site infection, obesity, overweight, diabetes, smoking, stoma formation, the only one that came out statistically significant was whether you had had a standard dressing applied to your wound. So the prophylactic PICO significantly reduced SSI, and with it the length of stay. Of course, this was a limited trial, single center, small numbers. Practice changing? Yes, in our institution. And indeed, this trial sparked a number of letters to the editor, numerous further trials, and a series of meta-analyses on this subject, of which 2 have come from Irish shores in recent times, and I've chosen this one from Shahil Sabali and colleagues in Beaumont. And I would like you to pay a special note to the control group incidence of SSI, ours at 32% by being no means the highest, and a clear favoritism across all trials of patients having negative pressure wound therapy applied to their laparotomy wound. This trial looking specifically, or meta-analysis looking specifically at trials using the PICO dressing run by Vicky Strugala and colleagues is very interesting reading, whereby it's reduced across a series of surgical subspecialities. And when we look at the numbers needed to treat in the colorectal arm, that is 5. 5 patients with a dressing costing €145 versus an elective colorectal surgical site infection costing you 10,000 sterling or more. And if you're not quite convinced yet, the Cochrane database in June of last year with moderate certainty have also backed negative pressure wound therapy for closed laparotomy wounds. At a similar time, we ran the stoma trial. And this was because during my travels as a trainee, I had seen when we reverse a stoma, a colostomy or a loop ileostomy, that different trainers closed the skin wounds in different ways. And thus we hypothesized that if we looked more closely, that the surgical site infection incidence would be less if you had a purse string approximation of your wound versus a linear closure. And we randomized 61 patients in this regard in Limerick, 34 to the purse string group and 27 to the linear closure. There was no difference in demographics across the groups, but a significant reduction in the surgical site infection incidence in those who had purse string closure of their wound. And interestingly, it would seem that if you developed a surgical site infection after a linear closure, this was a nastier infection because if you were readmitted, it was for a significantly longer period of time. And once again, for all patients who developed an SSI versus those who didn't, a significant increase in your length of stay in a time when we really want patients out of the hospitals as quickly as we can. And when we looked again at all the potential predictors, it was the type of wound closure that you have had which shone through as the significant one. Now, many people will say anecdotally that patients don't like a purse string closure of their wound. It doesn't look as nice, they're not as happy. That didn't ring through in our analysis here, with no difference at 1 month and 6 months in terms of patients' quality of life and satisfaction with their wound. And thus, purse string approximation significantly reduces the SSI incidence, along with it the length of stay, with no differences in patient satisfaction. And this is held out through a recent meta-analysis in 2019 for all stoma types favouring purse string closure, and specifically for loop ileostomies, of which our trial is included, favouring purse string closure. And as nice as it is to alter the surgical site incidence, infection incidence, through the way we close wounds, is there anything else we can do, or can we intervene even earlier? And our current randomized control trial, the CELDEC trial, which Ishwarya Balasubramanian presented at the ESCP New Trials Forum a little over 2 years ago, is focusing on this. And while we could talk for a long time about the benefits or not of mechanical bowel preparation, what we do know from the literature is that a combination of mechanical bowel preparation and preoperative oral antibiotics reduces your surgical site infection incidence. What we don't know is the role that oral antibiotics alone might play in that, and thus we're out to interrogate it. It's a prophylactic strategy for those of you who are not familiar with it, and ultimately where you're trying to get rid of the bad bacteria and keep the good bacteria. And why would we do it? Well, it's not new. And indeed, Nichols and colleagues back in 1973 randomized patients to a group getting neomycin and erythromycin preoperatively versus a group who didn't. And they showed that none of 69 patients in the antibiotic group developed a wound infection. A hugely impressive result. And I would put it to you that if we could all operate on 69 consecutive patients in the colorectal setting and not have an SSI, well then we might well retire on the spot. But this remains known. And this meta-analysis in the BJS, a journal with very good Irish heritage, back in 2013, looking at all gastrointestinal types of surgery, it concluded that preoperative selective decontamination of the digestive tract, i.e. oral antibiotics, decreases your postoperative complication rate and, interestingly, also your anastomotic leak rate. So clearly we're all using this. I mean, the evidence is there. And Liam Devan, albeit he was mainly looking at bowel preparation across hundreds of European surgeons, most of whom were senior, most of whom operating on 50 or more colorectal resection patients per annum. And as part of this study, he asked them, well, how many of you routinely give oral antibiotics before your operations? And clearly, based on that meta-analysis, you would think close to 100%. That's what it is across the pond. But in Europe, 1 in 10 of us. And that would certainly be what I saw during my training. And I think this is something that needs a close look at, and hence the trial, whereby we will randomize patients to 1 perioperative dose of Augmentin, or that 1 perioperative dose coupled with 2 doses each of neomycin and erythromycin the preceding day. There won't be any further postoperative antibiotics unless your operation runs for 4 hours or more, or you develop an infectious complication. And the primary endpoint will be the incidence of surgical site infection, with secondary endpoints as listed there, notably any other type of infection and anastomotic complications. And we aim to reduce the SSI incidence by 50%, needing to recruit over 300 patients to do this. And currently we're recruiting in both University Hospital Limerick and St Vincent's University Hospital Dublin. And I'd like to thank Deirdre Nally for putting this interim analysis together. We've randomized a little over a quarter of the number of patients we need to. And albeit there's no statistically different results here, there certainly appears to be a trend in the intervention group versus the control group in terms of the primary outcome. And we will feed back to you with the full analysis in due course. So having intervened at a wound level, having intervened preoperatively, we are surgeons, and we ultimately want to know, is there anything we can do with our hands that can improve the outcomes for our patients? And I was fortunate to be the first Irish recipient of the European Society of Coloproctology Travelling Fellowship to Japan in 2014. And not only did that afford me the opportunity to present at their national meeting, but also to visit a number of world-renowned centres, one of which was Fujita University Hospital in Nagoya. And this was my first introduction to the robotic platform. And indeed, apart from the bad posture, which I still have, this is my first time on the robotic simulator on the right. And immediately I was enthralled, and I felt that this is the way surgery is going, and I want to be a part of it. And having been proleptically appointed to Limerick, I was thus able to tailor my fellowship in the Cleveland Clinic in Ohio with a significant robotic emphasis. Of course, all these things come with a learning curve, and one cannot just jump on the robotic console and think that you can operate straight away. And of course, as I see amongst our trainees, everyone wants to operate on rectal cancer. And the learning curve for rectal cancer on the robotic platform is estimated to be approximately 39 patients. And if we put that in an Irish context, that is probably equivalent to about 2 years' work or more for an individual Irish colorectal surgeon. And thus it's very important that if we embark with new technology and new platforms, that we train appropriately. And there is the European Academy of Robotic Colorectal Surgery, of which I'm certified. And I think if you're doing rectal cancer surgery and you have a certificate which has Professor Bill Heal's name at the bottom, well, then you can't be doing all too much wrong. And having established the program, we of course need to know for ourselves, our colleagues, and most importantly, our patients, how we are doing. And Christina Fleming, with her time with us, looked at the initial 100 cases we performed in Limerick, of which the majority were for malignant disease, with a median age of 65 years. These are long operations, taking on average 4.25 hours, with minimal blood loss and impressive lengths of stay of 6.5 days for those undergoing colon surgery and 1 week for rectal surgery, with a 98.6% R0 resection rate, a 14 lymph node average, and a low SSI and anastomotic leak. And these results will stand up in the international literature. And indeed, they can be cause for celebration. And yes, indeed, the cake was very tasty. But of course, you always want to see the best in action and try and learn from them. And courtesy of the RCSI Ethicon Travelling Fellowship, I had the opportunity to visit Professor Sun Han Kim, who works at the Annam University Hospital in Seoul, South Korea. And he really is regarded as the godfather of robotic colorectal surgery. To put in context, individually he performs 400 colorectal resections per annum, 200 of which are robotic rectal resections. And when we think that in Ireland per annum there are approximately 500 to 600 rectal resections performed across the board. And interestingly, albeit no randomized data has shown an improved oncological outcome with the robotic platform, in Professor Kim's hands there is certainly a trend towards that in terms of improved overall survival and cancer-specific survival. And akin to Millin, Professor Kim is a publisher, and I was delighted with the opportunity to be able to write up his specific technique for how he tackles a robotic ultra-low anterior resection. And I would encourage anyone embarking on robotic colorectal surgery to read this paper. But it got me to thinking, well, if he's producing potentially better results in his institution with the robotic platform, how are we doing in our institution? And once again, Christina Fleming did a very nice study where she case matched our first 64 colorectal cancer resections with those of an established laparoscopic program in our institution. And as we can see, the majority of these resections were for rectal cancer, with right colon cancer second in line. And what we saw was a marked or a one-day reduction in the length of stay in those undergoing robotic surgery versus laparoscopic surgery. Very poignant again in these times, getting patients in and out of the hospitals as quickly as we can. And it's cheating a little bit, and I know that, but if you remove the complicated cases from each group, a significant reduction of a 2-day length of stay in those undergoing robotic colon surgery versus their laparoscopic counterparts. And what about oncological outcomes? Well, there was an R1 resection in both groups, and indeed in the robotic group, that was mine. But we are statistically removing more lymph nodes with robotic surgery, with the same pathologist examining all specimens. Whether this will transfer to any difference in oncological outcome, one can only think about it, but we will certainly return to you with that data in due course. And one of our current SPRs, Enda Hannon, has put together this nice paper because the robotic platform is heralded as the platform of choice potentially for that larger male suffering with obesity, the narrow pelvis and a dirty rectal tumor sitting down in it. And when he looked at patients non-obese with a BMI of less than 30 and obese with a BMI of greater than 30, our conversion rate actually is lower in the obese patients, with all other outcome parameters being similar, apart from the surgical site infection, which is increased in the obesity group, but we know that that is an independent risk factor in itself. And of course, having established a program here in Ireland, you always want to benchmark yourself about what is happening elsewhere. And in this collaborative work that is currently ongoing with Jim Kahn from Portsmouth and a number of other higher volume robotic centres in the UK, where Limerick is sitting here in the middle of the chart, we can see that over the years, from the establishment of the first program in the UK in 2013, it is being adopted more widely, with more surgeons doing it. And while, yes, we can get patients out of hospital quicker, we can't really show any oncological difference. What about the functional outcome? And this is what patients want to know, and traditionally maybe something that as colorectal surgeons we don't discuss well enough. Their urogenital function after a robotic TME or a TME of any type. And in our soon-to-be published meta-analysis in the British Journal of Surgery, it is clear that the robotic platform has favourable outcomes in terms of both urinary function versus the laparoscopic cohort, at both 6 months and 12 months postoperatively, and similarly in sexual function or dysfunction, the robotic platform is favoured versus the laparoscopic cohort. These are both in male patients. The findings are somewhat equivocal in female patients, but very important findings nonetheless. And while we can achieve equivalent oncological outcomes, it would certainly seem from the evidence base that you get an improved functional outcome if you have a robotic operation. Of course, personal accolades are very nice, but this is a team effort. And if it wasn't for the vision of our CEO, Colette Cowan, in the top left here, to introduce the robotic platform, coupled with that of Professor Coffey, well, then I wouldn't be presenting this data to you here today. And the team, of course, goes beyond the surgeon to the anaesthetist, the theatre nursing staff, the clinical nurse specialists, the decontamination staff, the allied health professionals. But ultimately, as surgeons, our team is as good as our trainees are. And what can we do, if anything, in terms of robotics and training? And Jarlath Bulger, during his time with us, looked specifically at this. And with the dual console, i.e. 2 operative stations akin to a cockpit where you can have a pilot and co-pilot alongside each other, you can also train your robotic trainee. And Jarlath looked specifically at 10 cases where the operator was the consultant alone versus 10 cases where the operation was shared between the consultant on one console and the trainee alongside them on the other. And while the operations were a little bit longer when the trainee was involved, this was not statistically significant and all outcomes were the same. And as part of training, of course, comes education. We've established the Sylvester O'Halloran annual robotic course. And unfortunately, it also marked the beginning of the pandemic last year when we had to cancel it 5 minutes before its commencement. We're living in an era of reduced operative exposure for trainers and trainees, and thus we must learn how to adapt and to continue to educate. And again, the robotic platform provides very good options with this. And as we can see here, this is a low anterior resection, me at one console and our trainee at the next. And the opportunity to video record everything gives us the opportunity to educate. And possibly not only should we review what we are doing, but we should preview, whereby we look at our videos, we can animate them here. I won't lie, I often didn't know what I was looking at as a trainee, but when we do this, we can clearly show our trainees where the plane of dissection is and where we would like them to go. And the dual console offers that perfect platform with no elbowing, let me take the operation, and the trainee never getting it back. Similarly, low down in the pelvis here, in an irradiated pelvis, we can clearly animate and describe that plane between vagina and rectum. And similarly, the use of fluorescence, which has been well documented by Irish surgeons over the years, is a very useful adjunct. And here we may possibly have stapled and left a slightly ischemic area in the upper rectal stump, but with fluorescence we can identify that and readjust our stapler accordingly. And what about going forward? Well, more and more, the paradigm of rectal cancer treatment continues to change, and we are in an era of organ preservation. This recently published study has shown impressive outcomes for patients having short-course radiotherapy and transanal resection, i.e., not undergoing a large abdominal operation with removal of their cancer up through the patient's anal canal, thus obviating any of the potential morbidity associated with a total mesorectal excision. And we await with interest the results of the Star Trek trial, but we will probably need to adapt on how we are operating on our patients, and thus recently we've performed the first robotic TAMAS operation on these shores. Laparoscopic TAMAS being transanal minimally invasive surgery, is well known, but how about applying the robotic platform with its superior view, great control and dexterity, and ultimately laparoscopic suturing, unless you're doing it very regularly in a TAMAS situation, is very difficult, and as the company would say, robotic suturing is intuitive. And for those of you who were attending at the video surgery meeting a couple of evenings ago, you will have seen this. A young lady in her 40s who felt to have an early rectal cancer on MRI imaging with no other negative features, who did not want a low anterior resection, and thus we offered her a robotic transanal minimally invasive surgery. And you can see the setup in the top right. Our principles remain the same, with adequate radial and deep margins. And yes, this did turn out to be an early T1 cancer with no adverse features. This lady left the hospital after one night, has no functional issues as a result of this, and will be under close surveillance going forward. And I certainly foresee that this will be how we are going to manage a lot of our earlier rectal cancer patients over the years ahead, based on the data that is being produced. And so back to Terence Millin, a surgical innovator and a surgical pioneer. Now I would like to think that this lecture has been in the spirit of Millin, whereby we have interrogated surgical technology and through animal-based laboratory research have shown how sacral nerve stimulation works and its application to the clinical context. We have looked to make small changes to reduce our surgical site infection, gaining traction with now evidence-based practice change in terms of negative pressure wound therapy. And we have introduced and validated, both internally and internationally, a new technique and program. And all three of these, of course, together to improve the outcomes for our patients. It's difficult to list everyone one would want to thank, but these are all those who have nominally trained me throughout my general and colorectal surgery years, and of course my MD thesis. Not listed here are our trainees, and I would like to thank all those who I trained with during my time and also those who have come to train with us in the last 5 years in Limerick. I would of course like to extend my sincerest thanks as always to my family and nearest and dearest who continue to tolerate me but also to provide their unwavering support. And lastly, I would like to thank you, the audience, for tuning in. I had hoped that I would meet with many of you after this for celebration and a chat. Alas, that opportunity isn't afforded to us now, but I very much look forward to when it is. Thank you.
Colin, congratulations on your lecture, and I'm delighted to present you with this, the Millin Medal, and to know that you will join a long list of distinguished Irish surgeons who have contributed so much over the years. Congratulations.